So now I have the distinct pleasure of introducing Dr. Ira Lott, my colleague from UCI Mind. Dr. Lott is a pediatric neurologist at UCI. He is previously the chair of pediatrics, and he is not only a pillar in the field of understanding Down syndrome and especially Alzheimer's disease and Down syndrome. He is very much a pillar of the local community here in Orange County. He's a hero to families, and it's been a real honor for me to watch him work and to learn from him in my brief time at UCI. He's really a fantastic clinician scientist. We're very lucky to have him, and I know that the families dealing with Down syndrome and Alzheimer's disease in Orange County feel even stronger than I do about that. Dr. Lott.
I want to start by thanking the previous panel, and particularly June Brucey, for the privilege we had of caring for Ruth. I am a pediatric neurologist, and I'd like to paint the picture of dementia and Down syndrome from the neurological perspective. Down syndrome is the most common genetic form of intellectual disability. The prevalence is about 1 in 700 live births. The link between Down syndrome and Alzheimer's disease has been known for over 68 years. But at the time that I went to medical school and did my training, children with Down syndrome were rarely treated for the conditions that increased their mortality. And so they did not survive very long, and they did not show manifestations of aging for that reason. Organizations like the Down Syndrome Association of Orange County have been active for decades in lobbying along with other national groups. And in the 70s and the early 80s, the United States Congress passed laws about people with disabilities, many of whom had Down syndrome, about treating the conditions early in life. Now, children with Down syndrome are treated and they grow up, and we are able to see in a more longitudinal manner the effects of development and aging. This, by the way, all of the pictures I show you, the families or the participants have given me permission to share. This is kind of a moving picture of a man who was 40 years old at the time this was taken, with a very fast-moving form of Alzheimer's disease, being comforted by two of his friends. Now, the issue here in Down syndrome is by the age of 40 years, all people with Down syndrome have neuropathological changes in the brain of Alzheimer's disease. This is the only population in the world that we know in which there is such a ubiquity of neuropathological findings by the age of 40. However, the prevalence of dementia is variable, and it's around 10% at age 30. And when we get up to 60 to 69, it has been measured between 55 and maybe 75%. The point here is that dementia is not invariable, even though people with Down syndrome have changes in the brain of AD. And why some come down with dementia and others do not is one of the compelling biological questions that informs not only Down syndrome, but the field of Alzheimer's disease, and has been one of the focuses of our own research. Dementia has been defined clearly throughout this conference. It's a general term that refers to progressive loss of memory, judgment, language, complex motor skills, and other intellectual functioning. And Alzheimer's disease, as you've heard very clearly so far, is the most frequent cause of dementia. This is a representation by Elizabeth Head, who I think is our major collaborator, and I consider to be the leading neurobiologist in the country on the relationship of Down syndrome and Alzheimer's disease. This slide from Dr. Head shows a characteristic amyloid plaque and a neurofibrillary tangle. For all the world, it looks exactly like the pathology that we see in sporadic Alzheimer's disease. What is different in Down syndrome is that the amyloid is deposited across the lifespan, starting in infancy, going through adolescence, young adult life, and then older people with Down syndrome. And Liz Head and others found a way to label the amyloid with an aspartate residue so one could determine how old it was and where the amyloid was first deposited. So here is an early depiction of a very diffuse amyloid plaque in a 4-month-old brain from an individual with a child with Down syndrome who succumbed to a different problem. But you can see that those holes represent intact neurons. So there's this diffuse amorphous amyloid which is in the brain for generations in Down syndrome. And the senile plaques have the, quote, benign appearance. So you see these holes here which represent intact neurons. After the age of 40, to a variable degree, the plaques go from being diffuse plaques to what are known as cord plaques. And those are the pathological plaques associated with Alzheimer's disease. They're made up of beta amyloid protein, cleaved from amyloid precursor protein, and of course they're very toxic to neurons. You can see the progression of amyloid in Down syndrome. Here's a 31-year-old person with Down syndrome, and you can see the amyloid accumulation compared to an 86-year-old person in the general population who is not demented. And you can see what happens with the presence of dementia. There is a great increase in both new amyloid and old amyloid. The oldest amyloid are these dark areas which are highlighted by the arrows. Now, of all my slides, this is the one, as a pediatric neurologist, that has the most interest to me. These are, quote, benign plaques from an individual in early adult life in Down syndrome, and you can see the holes, which represent intact neurons. But on closer inspection, you see those little red dots in the holes, and they represent activation of an enzyme called caspase. Caspase is a very bad actor. It leads to cell suicide or apoptosis. So even in the benign plaques in Down syndrome, there is evidence that an apoptotic process is at work. Now, what this means to me, if we are able to find an efficacious therapy for older adults with Down syndrome offers a platform for stepping back to earlier age epochs and treating the benign plaques at a time when we might actually change cognitive functioning and prevent the progression to Alzheimer's disease. So once again, Down syndrome provides a very interesting model for considering how amyloid across the lifespan may contribute ultimately to dementia in Alzheimer's disease. Once in a lifetime, a special case comes along, and I met this gentleman about 8 years ago when he was 66 years old. He came to our Down syndrome clinic. He said, "Dr. Lott, I apologize for being late, but the receipts for the cash box didn't add up, and I had to work on the finances." There's a 66-year-old man with Down syndrome. So I said, "I understand." He said, "You need to promise me one thing. You will not discuss my medical condition with my brother." I said, "Okay." Turns out his brother was really very supportive later on. I said, may I ask why? He said, because my brother and I do not share the same philosophy of life. So I said to my research manager, check his chromosomes. And sure enough, this gentleman, who we will call JJS, had a very rare condition called a partial trisomy. This is not a mosaic. This is a situation in which part of the 21st chromosome is missing. So this is his picture, and for all the world, he looks like a typical person with Down syndrome. Our geneticists could not find any significant difference in physical appearance. But this is a simplified diagram of the missing segment of his chromosome, and you will see that that segment includes amyloid precursor protein. So this was a rare individual who had 2 copies of APP, not 3. And so we had the privilege of looking at him longitudinally, starting at the age of 66, to see whether, in fact, he was going to develop dementia or not. Here are his neuropsychological test scores. This is a specific battery for dementia and Down syndrome. And you can see they go up a little bit, they go down a little bit, but they in no way change like the changes occur in Down syndrome with Alzheimer's disease. So basically, his standardized neuropsychological testing showed no evidence of dementia. In addition to that, we did 2 amyloid scans, one in 2009 and one in 2012, one at UC Irvine, one at UCLA, and neither scan showed any significant amyloid uptake in the brain. A very unusual situation for Down syndrome. So he had no dementia, he had no amyloid by PET scanning, and he did pass away eventually of unrelated medical conditions. And we had the privilege to examine his brain, Dr. Ron Kim and our neuropathology core of the ADRC. His brain weight was consistent with Down syndrome, which is about 5 to 10% reduced over the general population. Remarkably, he had no amyloid neuritic plaques and basically showed only signs of normal brain aging. So this is what this case is teaching us, in my view, that triplication of APP is mandatory for dementia and Down syndrome. And when there is only duplication of APP, there are no clinical, cognitive, imaging, or neuropathological findings for Alzheimer's and Down syndrome. And this is going to be published shortly in the Journal of Alzheimer's Disease. So one case can have a tremendous illustrative value in regard to how we think about the evolution of dementia and Down syndrome. So let's talk for a moment about how dementia presents in Down syndrome. And I have a list here, and they're not necessarily in the chronological order. The first thing that occurs is a personality change, and you have heard some very specific lectures about the frontal deposition of amyloid and tau and how personality changes in Alzheimer's disease, Lewy body dementia, and frontotemporal dementia. In Down syndrome, the first change appears to be social. People with Down syndrome, as a rule, are very outgoing. They have a very strong streak of humanity. And what we have seen over the years is the spark sort of goes out. They lose their interest in going to the church social, or they lose their interest in going to the workshop. And their speech changes in that it is no longer socially communicative. Linda Nelson published a paper with us a number of years ago in which this loss of communicative speech she called pragnosia. as a very early manifestation of dementia. There's a loss of activity of daily living skills. It's not that they're paralyzed or they lack the strength to do it. They just can't figure out the complex motor tasks that has to attend to their dressing, their bathing, their toileting. And one of the big manifestations of this is a change in their gait. And I think this is an underappreciated area of Alzheimer's in the general population. We find that our patients with Down syndrome lose perception of their feet in space. So they come to a crack in the sidewalk, or they come to a stair and they absolutely don't know what to do. It takes them forever to get out of a van. And this is not because they're weak or they're paralyzed or they're hypertonic. It's because they cannot get the coordinated movement together. And so far as we can tell, that is a frontal lobe function that changes early in the course of AD and Down. So this change in gait. New onset seizures seem to have a dire consequence for adults with Down syndrome. And it's quite interesting. Children with Down syndrome get seizures, and sometimes very severe seizures, but they grow out of it and they're easily treated. But when seizures occur after age 40 in Down syndrome, they seem to have a different significance. And I'll come back to that in a minute. There is a differential diagnosis that's critically important in making a diagnosis of dementia in Down syndrome, just like it is important in AD in the general population. People with Down syndrome tend to have an autoimmune thyroiditis, so their thyroid function can be low, and that's very easy to mimic dementia. A person with an intellectual disability who has a sensory problem in hearing or vision may appear as demented. We know people with Down syndrome get cataracts early. And, you know, those of us stand cataracts for a certain period of time, but it has negative consequences for people with Down syndrome. Sleep apnea is a recently appreciated problem in both AD and in Down syndrome. People with Down syndrome tend to have a small oral pharynx, and they tend to have a big tongue. So their tongue flops back on their airway, and they get obstructive sleep apnea. And obstructive sleep apnea can worsen cognitive functioning. So what I'm talking about here are preventative conditions that are part of healthy brain aging, and they need to be considered in Down syndrome. Likewise, if a person has a systemic illness or they've developed a primary depression. We had a free-form meeting at lunch today, and we heard about a young man with Down syndrome who suddenly had a regression in abilities. Not Alzheimer's disease, probably not primary autism, but some type of psychiatric depressive-related continuum. This has now been described across the country. People are still scratching their heads about what this means in Down syndrome, but it is on the differential diagnosis. And then there's the issue of medication. We had a patient referred a couple of years ago for dementia. Doctor said, this patient's becoming demented. He was on 12 different psychoactive medications. So he appeared obviously demented, as any of us would, until that was straightened out. We also see a failure of medication compliance that presents as dementia. The former Surgeon General of the United States said medications tend not to work if people don't take them. So if someone has been prescribed medication and is not taking them, that can have negative consequences. So here's a bit of a summary of the conditions I've been talking about. You see the prevalence of visual impairment, hearing impairment, in Down syndrome compared to controls. You see epilepsy, you see thyroid disorders, and then, of course, you see dementia. Now, one of the recent observations has to do with chronic inflammation in the body and whether this could be a trigger for dementia. We know that people with Down syndrome have a special autoimmune condition and they're prone to inflammation. So what can be in the body of a person with Down syndrome that causes chronic inflammation? And this is a recent article that looked at periodontal disease, otherwise known as simple gingivitis. We know that people with Down syndrome tend to have poor dentition. We know that doctors don't know much about dentition and don't pay a lot of attention to it. So here's an extreme example of a man with Down syndrome in his 50s who lost his teeth because of chronic periodontal disease. Well, that's an inflammatory circuit that keeps going and going and going and going. Is that triggering dementia? Is it related? And I'll come to that at the very end. One of the questions that we asked as the result of this medication, do people with intellectual disability in general take their medication? We know that people in the general population don't take medication much of the time. So we had an opportunity to look at 793 individuals with intellectual disability, followed by the Regional Center of Orange County. We were able to look at their medication compliance over a 30-month period by looking at their pharmacy billing records. And the bottom line is this. If a person with Down syndrome lives in a group home, they receive their medications 95% of the time. However, if they live semi-independently or they live in the family home, they miss their medications a third of the time. And this happens to be a study of anti-epileptic drugs. So the consequence you can see, trips to the emergency ward. By the way, the same is true for cardiac drugs, hypertensive drugs, diabetic drugs. So medication compliance is a big problem when you're trying to figure out dementia and Down syndrome or in the general population, particularly in these populations that live semi-independently or in their family home. Now I want to turn to a moment to another neurobiological observation. This is a paper we published with Richard Heyer a number of years ago, and this is a glucose utilization scan of the brain. And we looked at a number of young adults with Down syndrome who were not demented. What we found, and what is shown by the yellow markings on this scan, is that there is an overutilization of glucose and increased glucose uptake and utilization in the very parts of the brain that go cold in Alzheimer's disease. So this suggests in Down syndrome before the onset of dementia, there is an overactive part of the brain, mainly the mesial temporal lobe, the exact part of the brain that goes cold in Alzheimer's disease. And we were able to, again with the support of Elizabeth Head, to look at our post-mortem material that has been collected through our ADRC, and there is neurite sprouting in this area, suggesting that the brain is trying to compensate for the beginnings of an Alzheimer process. And so that sounds good, right? That it's trying to compensate, it's making new neurite sprouting. But too much compensation, too much overactivity can trigger seizures. And this is where I think this link is between a compensatory reaction and a negative reaction. So a couple of years ago, we were funded by the NIH to carry out a trial with high-potency antioxidants in adults with Down syndrome and dementia. And these were vitamin E, vitamin C, and alpha-lipoic acid. And there was a large animal literature to show that these antioxidants were very robust in preventing cognitive decline in beagles who mimic Alzheimer's disease. Now, I'm told the beagles aren't too smart to begin with, but there's a certain breed of beagles that has changes of Alzheimer's disease. And this cocktail prevented that. So we thought, great, worth a human trial. Did not work. It supported our fear that once dementia sets in, we're not going to be able to do very much. But we looked at a subgroup that went downhill so quickly that we couldn't test them anymore. And we looked at all of these variables, and the odds ratio of having this severe decline on two of our major neuropsych tests was nearly 12, which is huge. So there's a very strong association of seizures and cognitive decline. And I would also say this is true in Alzheimer's in the general population. There's a very nice review by, who is the fellow who did this? Come to me in a moment. A couple of years ago that talked about amyloid beta in the temporal lobe and epilepsy in people with Alzheimer's disease and described it as a perfect storm. So I think this is the Down syndrome equivalent of this observation. So let me conclude here with something a little different. Where are we going from here? I mean, we know how to diagnose dementia with Down syndrome, and because of work at UCI Mind and other centers around the world, people with Down syndrome are now eligible for clinical trials. I have to tell you, shortly after I came to Irvine, I called someone in the FDA who shall remain nameless, and I said, I'd like people with Down syndrome to have access to this new drug, which was then called Tacrin. Do you remember the drug called Tacrin? It was a terrible drug, but it was the only drug that we had in the field of AD. So the official at the FDA said, that's interesting, but because of the intellectual disability and Down syndrome, we don't see dementia. So I gave him my favorite quote from Sherlock Holmes, where Watson says to Holmes, Holmes, I don't see it. And Holmes says to Watson, nonsense, Watson, you see everything, you recognize nothing. Well, he wasn't too amused with that, but you know, that was the challenge, that we could diagnose dementia and get people with Down syndrome eligible for clinical trials. And there are going to be many clinical trials coming down the pipeline for Alzheimer's in the next few years. You know the national effort that has been put in this by the NIH, by the pharma companies, and people with Down syndrome will be eligible. So who is at most risk for Alzheimer's disease? And so we have a new grant, which is now called a U01, which is a cooperative NIH research grant. We have 6 co-PIs, Irvine being one of the leading sites, 11 sites around the country, and it's a longitudinal study of biomarkers. So we're going to look at spinal fluid, we're going to look at blood, neuropsychological testing, amyloid PET, and genetic testing. And we're going to follow this prospectively in up to 800 subjects total. Be the biggest study of this issue in Down syndrome. And we hope to find a panel of biomarkers, whether it's proteomics, lipidomics, candidate genes, that will predict who is at the most risk for cognitive decline. And so this is a parallel study now in Down syndrome to the ADNI study, which many of you will be familiar with in the AD field. So it's a big deal for all of us who have been working in the area of Down syndrome. So we know that intervention must start before dementia begins. We have to work on defining mild cognitive impairment in Down syndrome. It's well defined in AD population, but not in Down syndrome yet. And that's one of the goals of this current U01. And we want to find out if the biomarker profile has strong predictive value. In doing this, we developed a rapid test for cognitive functioning, because the neuropsych panels are very detailed and not always available. And David Walsh in our group in 2007, another paper in 2015, developed a rapid assessment for developmental disabilities, which has very good retest value and correlates very highly with the other known measures of dementia and Down syndrome. So we feel like we've got a good handle to follow this progression. So what kind of clinical trial shall we choose in Down syndrome? And a colleague at UC San Diego, USC, is Mike Raffi, who's worked in the area of clinical trials, and he published a review this past year. The choice of the clinical trial has been based heavily on mouse models of Down syndrome. We haven't talked much about animal models today, but the mouse model for trisomy 21 has been, there are thousands of papers, very well studied, and suggested several therapeutic effects. But we need to have special considerations for Down syndrome. There may be those in the audience who remember the days when drug trials for people with intellectual disability were carelessly applied and informed consent was not obtained. So we must always weigh our enthusiasm for the drug versus the potential side effects in a population that cannot always speak for themselves. So let me just leave you with one of those. We talked about inflammation from periodontitis was just an example. This is a paper published by Donna Wilcox last year, and it looks at the brain of individuals with Down syndrome and Alzheimer's disease in regard to a measure of neuroinflammation. In this case, it was HLA immunoreactivity. And Andrea Tenner was one of the first to talk about the inflammatory cascade in Down syndrome many years ago. Here are normal controls: a young person with Down syndrome, a person with Down syndrome and Alzheimer's disease, and a person with Alzheimer's disease. And this is the percent of this neuroinflammatory change in gray and white matter. What this shows is there's a pro-inflammatory state in Down syndrome. We would love to get amyloid out of the brain, and there's a national clinical trial in A4, and it would be perfect for Down syndrome, but one of the considerations we're weighing is whether such an active vaccine trial would be safe or not, or we need to have another approach. And everybody's thinking about this with us, Mike Raffi, Donna Wilcox, and so forth. Because in the end, we have to follow what every medical student is told on the first day of medical class. They're told in Latin, primum non nocere, first do no harm. So because Down syndrome is a special population, we have to have this added care. But I'm convinced that we will find a way to institute clinical trials, to continue to make the correct diagnosis, to do the correct differential diagnosis, and ultimately benefit people with Down syndrome who continue to teach us about all these processes that are important to us all. So I'd like to acknowledge our grant support from the NIH, the Alzheimer Association, and I'd like to acknowledge my research manager, has been with me for 15 years, the faculty, many collaborators within the ADRC and UCI Mind, and finally, most importantly, I'd like to acknowledge people with Down syndrome. Thank you.
So I think we have time for one or two questions. And we have intellectual microphone roamers call.
There's obviously been a lot of study done on people with Downs in relationship to Alzheimer's. Has anything been done with other population of intellectual disabilities in relation to Alzheimer's?
So the question was, what about other people with intellectual disability? It turns out that the risk of Alzheimer's disease in non-Down syndrome populations is very low. It's equal to the general population. So Down syndrome appears to be the only form of congenital intellectual disability with its predilection to AD, and we do think that's because of the triplication of APP. So I think that stratifies the risk. Yep.
One more? Okay, thank you, Dr. Lott.
Thank you.